Good afternoon and welcome to all of you. This is our PSQI learning series. We provide a range of services across health systems management. And we use a systems thinking approach. So these are some of the services we are offering, and we want to create awareness out there. We want to ensure that our patients get the best and quality care. So for us to get quality care, we have to strengthen our health systems. We have to adopt system thinking, and some of the approaches we use are the ones that we try to share the knowledge about. And if you need some of these services, you can always reach out to us. And so that's why we are doing this. So just for housekeeping, I believe all of us are well now used to these online meetings and so on. So these are some of the things you can do. You can, if you're not getting the sound clearly, these are some of the settings you can ensure are working, like ensure your speakers are working well, adjust the volume. You can also feel free to use the chat to send in your questions, and also network. You can network with people in the chat. You can connect on LinkedIn, X, because you never know. You might land an opportunity from such forums. And also, when in the meeting, just mute yourself so that we keep the house in order. So the other thing, we'll be recording these webinars, and the reason for recording is for continuity. We want to ensure that this knowledge that we share here keeps being passed on. So the recording will be shared to all participants in your emails, and we'll also be uploading them on YouTube. So it's important for you to know that we'll be recording them. If you want captions, you can always turn them on. And then the other thing that we will be doing in this session is to conduct an entry and exit survey that will be done by our presenter. And just like I said, this session will be recorded for continuity and also for learning purposes. So with that, feel welcome. My name is Stella Oiro. I'm your host for today. And therefore, I'll just go ahead and welcome our presenter for the day, Odoro Tieno, who will introduce himself and then take us through our session for the day. Thank you.
Thank you, Stella, and welcome, colleagues. Thank you for creating time and finding time to join us today. So, colleagues, welcome. My name is Odoro Tieno. I serve at Systems Evaluation as the Patient Safety and Quality Improvement Lead Advisor. And this is part of, this session is part of the series, our learning series, basically to ensure that the health workforce is capacity built to keep patients safe with regards to the demands of the 21st century healthcare working space. And our sessions for these sessions is basically a continuation of the previous one. We're just trying to see how to tie the information, the learning we had in the previous session with this one together. So as always, from the slide there, from the slide here, this is just a session for us to have an overview. So there's some, just like the way we prescribe medication for patients in the hospital setup. So this is also our session to have some dose of QI and patient safety thinking in this session, in the space. So with this session, this is just a brief of the session overview. with this session, we just highlight some high-level architecture of what patient safety strategies can be implemented within our setup. And the focus here is resource limited and constraints within our setups. That's, I believe, is where we mostly practice in. And we also highlight how these system-level safety strategies support us, help us in mitigating systems migration. Our previous session was concerned with how safety systems migrate over time to put patients at risk or in harm's way. So this session is highlighting how some of these strategies can enable us mitigate those migrating systems. And also this is part of the practice where we try to build capacity of health workforce and also inbreed the culture of safety. Our hope is that by the end of this session, we will be able to at least identify some of the key safety strategies, patient safety strategies, and how to blend them with a view of having low cost and practical patient safety strategies that we can apply within our setups. So to get us going, just the numbers with a global context, and here our focus has been mostly within the lower middle income countries. On the red box, these are the global figures with regards to the LMICs. And if you look at what is out there, and I know most of us, we've seen this previously, the patient safety burden is enormous. And for every 400 people, 4 will die from unsafe care. And that is basically within the setups that we operate in. And annually, we're looking at up to 8.4 million deaths that is attributable to poor care. And when you look at this is basically 15% of overall deaths across the LMICs. And for us who are in the hospital setups, 10 to 15% of hospital admissions will result in more than one AE adverse event. And 30 to 50% of this is basically preventable. And for the context for our context in lower middle income countries, this is fairly higher than the global average of preventable adverse events. And when you look at the economic impact, we are looking at about 1.6 trillion in lost productivity. And the 33% you see here, this is the value of the national budget we had as Kenyans this year, 2027, 2026, 2027. So about 33% of that 4 trillion budget is goes to taking care of unsafe care, and approximately 1 to 2% of GDP cost in terms of avoidable healthcare expenditures. And there is a figure here especially for those of us who practice in Kenya. Sometimes back, we had a Kenya patient safety impact evaluation, and about 32% of health facilities in terms of compliance across the patient safety intervention domains, be it hand washing, be it high PC practices, be it safe surgery practices, our compliance rate globally, cumulatively, was about 32%. So that is just for the numbers. There are also challenges in terms of implementation of patient safety strategies. And some of these challenges are plentiful. And when you look at in our practice areas, I believe we might have interacted with some of these challenges that make it basically difficult for us to implement some of these patient safety strategies as they are. So commonly, we talk about resource constraints and infrastructure deficiencies, whether you're talking about IPC infrastructure, where you're talking about safe surgery care infrastructures, where we're talking about hand washing infrastructure. So the constraints are enormous, and it hampers how much or how easy or how fast we can implement some of these patient safety strategies. The other one is workforce shortages, and I think this is not unique for us. In most of the spaces that we work in, we grapple with workforce shortages, training gaps, and that is where one of this session of ours also comes in, because we do realize that in most cases we get into practice and we are fairly not inducted into some of the interventions or the approaches uh, for providing safer care. And the normal issues now also with workload, with workforce shortages, workload issues will also come in. Uh, close to that, close to that is weak governance and leadership issues. For example, when you talk about leadership and governance issues, uh, in the most recent global patient safety action plan, you realize that most countries have not implemented or even put in place the national patient safety action frameworks. And this one also goes to speak to even the facilities, the health facilities, because we know most of these patient safety frameworks are not in place in a good number of our health facilities. And if the Kenya patient safety impact evaluation is something to go by, you'll realize that up to 32% being our compliance being up to 32%, it means that we have a shortfall of a great deal of facilities that are non-compliant, and it therefore goes to mean that their governance structures and leadership with regards to patient safety is also a challenge. We also do grapple with a lot of poor data quality issues with regards to patient safety interventions and quality of care interventions, whether it is just patient safety surveillance practices or just the reporting systems. So this is a challenge with most of us who practice within the LMICs. Another one is limited patient and family engagement, and this is an area where for us in the LMICs, we are not doing so well, in that we still practice so much of a paternalistic approach to care. And given the traditional informational asymmetry within the healthcare space, uh, family engagement, patient and family engagement is a great deal when it comes to implementing patient safety strategies. So that remains a challenge. And overall, also financial and systemic barriers in terms of the financing approaches for patient safety interventions, quality of care interventions, because traditionally most of our financing approaches, we are fairly blind, or somehow going slow in deliberately investing and financing patient safety interventions and quality of care interventions. These challenges are, as you can see, they are always interconnected. They don't come alone, and you'll not experience them in silos. You'll always have these challenges interconnected, because one challenge here impact on the other. The workforce shortages will also impact on how patient safety data is collected and analyzed and utilized. Uh, Resource constraints will also impact on how family engagement interventions are implemented within the country. And when you look at now the diverse countries, there are some countries that are way ahead. They've got for example, national patient safety strategies on course, and some countries are fairly lagging behind. And that also goes to say that within the health facilities that we work in, or the health organizations within the specific countries, progress will also be fairly uneven. Overall, these challenges contribute to implementation gaps, whether at health facility level or at country level. So from these challenges, we're going to highlight some of the strategies that are proven to mitigate or step in to address some of these challenges whenever we are thinking or we are intentionally implementing quality improvement challenges. And this is based on the work, following from the work that we referenced last time on the systems migration by Dr. Rene Almalbati and Professor Charles Vincent. And that is basically the follow-up of the interventions that we are looking at here. And the advisory and the guidance is that it is a fairly neat approach whereby there is no one strategy that fits all, but a combination of strategies, especially with the view that the clinical setups we operate in are also diverse and they come with their own different challenges, whether in terms of workforce capacity, whether in terms of infrastructure capacity, or even the types of patients and families we engage within the workspaces that we operate in. And that is why in terms of thinking through how to implement patient safety strategies and interventions, it's good to think around the mosaic, around these five key areas. And the first one, for each patient safety challenge or area that you would be considering to implement a QI or a patient safety intervention, the first or the primary baseline is using patient safety, that intervention as the best practice within that facility or within that unit. And here we are looking at each and every intervention being implemented with the view that it matches or meets the standard of care that is that is defined or prescribed for that level of care or for that type of intervention. The next strategy is to look through the processes, basically a process approach, whereby the view here is to ensure that whichever strategies are being implemented, you look through the entire pathway or the entire continuum of care delivery for that simple intervention. We'll see how these ones tie up. And the other strategy is about risk control, where for each and every patient safety problem or patient safety challenge, we look at how do we manage risks that come with delivering that care. That is the essence of risk control. And basically here prescribing when to restrict care, when to manage access, especially when the environment or the system is deemed unsafe. The other strategy is looking at monitoring and adaptation. For example, for each and the patient safety challenge or intervention, how do we monitor the interventions, the strategy interventions being implemented, and how do we take care of the other challenges or the outcomes of the patient safety harm or adverse event when they come? How do we report? How do we respond? And how do we also adapt in real time? The other strategy that closes up the loop of the five is mitigation. With each and every patient safety challenge and intervention that you are implementing, you need also to think through how do we step in the event that harm actually occurs. Basically, planning for how to mitigate, stepping in and basically restoring the status as it would be. Looking at these five strategies, two of them, the first one, for the first two, that is safety as best practice and improving healthcare processes, these are fairly designed or targeted towards optimizing care at the patient level and the family engagement level. So that is the key or the focus of the first two strategies. And the third, the remaining three, that is risk control, monitoring and adaptation, and mitigation. They essentially looks at how do we optimize the care in the event that strategy 1 and 2 has failed. That is when now the patient has, for example, when now harm is drifting towards service delivery. And as always here, the key takeaway is that for each and every patient safety intervention or patient safety challenge, we implement a blend of these strategies. Because if you implement one and leave the others, there's still that just so much gap that you are yet to cover for that patient safety intervention or patient safety challenge within the organization. Closely now in the next series, we just want to highlight how some of these strategies fall through with the various interventions, and maybe with also a few insights or examples that have come through. So when you look at the first strategy, that is safety as best practice, the focus here is usually to manage to ensure that we are reducing harm within the system and also improving reliability. And with this, there are various interventions. Whatever I am highlighting here is just an example. It's not exhaustive. It's just an example. For example, when you look at reduction of harm, this is where, for example, you'll be speaking about minimizing or reducing patient falls within the setup or within the organization. You'll be looking at interventions to reduce urinary catheter use and infection. You'll be looking at intervention to reduce central line infections. You'll be looking at interventions to reduce pressure ulcers within the unit, for example, for patients who are admitted into your unit for prolonged time of care. Sorry, I was just admitting someone. And the other focus is also looking at improving reliability of the processes. And the key one of the easiest, the most prominent example here is the surgical safety checklist that we have within our operating theaters. This is one approach to ensure that the process is reliable and it's basically done the same way by the same care teams through and through. And that is the same platform where we're having our protocols and other checklists that we may have. An intervention around medication reconciliation, whereby, for example, when a patient is coming into the unit, if this patient is on any chronic care medications, the admitting staff or the admitting team reviews the medications they are on, and a reconciliation is made. You are coming into the unit. This is the next set of medications that have been prescribed when you're in the unit. And probably when you are exiting care, when you're now moving to the care is being stepped down or maybe by way of discharge, also looking at how are the medications that the patient came in with and the ones that patients are going out with interrupt or affect patient care moving on forward. So this is just an example of interventions that looks at improving reliability of the process. Another one might be around supply chain issues, the health products and the health products that we have within the organizations, whether they are non-farms or pharmaceutical products. How do we ensure that we are consistently in supply? The supply pipeline is consistently having products for us, so that this is with view of resource gaps and shortages. So when we look at this intervention or this particular strategy, there are also a number of an example. My cursor is okay. It has come back. So these are just case examples from how a large scale large-scale implementation of some of these interventions. And one of them, the commonest one, is the surgical safe surgery checklist that we've had. And this is an example from, I think this was tried out across hospitals in Mozambique. And the outcome was that it reduced major complications from 11% to 7%, and also mortality from surgical care dropped from 1.5% to 8%. The other one was also still within the same environment. Sustained use of the surgical safety checklist, basically being improved, linked to improvement in safety culture within the organizations. So with regards to the discussion we had previously on safety migration, the use of checklists and protocols, for example, the safe surgery checklist, enables the system or the care team to arrest early drift or early migration from the safety zone. I think we had 3 zones. The practice zone, that is the safety zone, zone 1, where everyone else is expected to operate and play. By the virtue that we have a surgical safety checklist, for example, we are building reliability in the process. We are building reliability within the teams that organize, that provide the care. And this prevents early drift from the unsafe zone to now what we called in the previous session, the illegal normal, or the normalization of deviance in the first level. So that is how the strategy 1 enables us to now arrest migration of the safety systems within the healthcare organization. We move to the second strategy, where now we are looking at improving the healthcare processes across the entire continuum of the care and the system. And when we look at improving the care processes, here, the intervention focus should be on the individual staff within that team providing care, the task at hand, the team providing care, the work conditions or the environment, and the organizational interventions, whereby now for the individual staff, we're looking at, for example, the list is not exhaustive. This is just an example. Training in key clinical processes, and also providing staff with feedback on performance. When we look at staff task interventions, standardizing what needs to be standardized, and also automating key processes that can be automated, and also improving the design of equipment that we use. And for example, in the age of computing, the user interface of most of the devices that we use, in terms of making them user-friendly, I think, in terms of the tasks, and also team standardization, how the team provides care within one unit and the next unit should have an element of standardization. For example, when the shift is changing, how team 1 hands over the patient care or the shift to the next team should be fairly standard across the organization. How teams allocate roles or identify their roles within the care delivery team also should be formalized and standardized, so that the roles are clear and everyone else within the structure is able to identify which roles they play within the care delivery teams. Working conditions, this is basically the environment we work in, whether it is just lighting or even improving the workstation design. Okay. And also with regards to minimizing interruptions within the care delivery processes, and also organizational interventions, improving the levels of, for example, workforce management, staffing, or commodities availability within the organizations. So that is where now the strategies are looking at strategy 2 now comes into step in. Now, an example from how this strategy was implemented, and this is a case in point from an implementation, a large-scale implementation within the Ethiopian healthcare system. And here the intervention was targeting or intended to reduce surgical site infection. So when you look at now the process of surgical care, for example, from let's tie it from what we had in the previous slide, you would have a surgical care checklist as one part of the process. You'll have let's say hand hygiene as one part of the process. You'll have one element as let's say skin preparation or the incision site preparation as part of the process. So when you are implementing that intervention around the problem or the challenge of surgical site intervention, you look at the entire process of care around that intervention. And for this particular case, for this particular application, the team looked at six core processes that impact surgical site infections. And with the feedback of improvement in terms of improvement in terms of surgical care, site infections, and the process adherence here. Also, this is also attributed to now adherence with regards to the use of surgical safe surgery checklists. And through this implementation, they recorded an improvement, a jump from 16% to 43%. So the essence here, if we are implementing a strategy around an intervention or around a patient safety challenge, we look at the entire process or the entire care process or journey that impacts that outcome. And we link this with the systems migration simply because it enables us now to identify and mitigate the latent conditions within the organizations that may enable drifting or may enable systems migration. And such as issues like chronic understaffing comes in when, for example, when we consistently apply our surgical safety checklist, we are able to pick the gaps that we have, and within the team, as we develop the team, which roles can be shifted or which roles can be shared to enable us basically now mitigate the issues with staffing challenges. The third strategy is on risk control. And on risk control here, the focus will be now determining when do we need to withdraw the service, when do we need to reduce demand, and when do we need to place restrictions on which services can be provided at various times or by which care teams, or how do we prioritize which care types to deliver or care packages to deliver at which types of the care. For example, these are just also not exhaustive. We've seen instances where a service unit is temporarily closed when, let's say, a patient incidence or harm comes in. We've also realized that there are also sometimes when we reduce or manage patient flow temporarily when demand or the capacity to provide that care is not available. So, for example, when you are looking at capacity to provide care, for example, in a surgical unit over the weekend, you may not have the entire workforce with you. So that means that you establish or maintain the team to step in, especially for critical and emergency care. But now for elective cases, we reschedule them or we plan them within the system when we have optimum workforce and optimum organizational capacity to provide that care. That is what risk control and risk management looks at. It also looks at having a defined criteria of a no-go care area or a no-go investigations for a particular team that provides care or a particular service delivery point or at particular hours. So, for example, You may have a no-go zone for certain types of, let's say, investigations within the lab, with a view of that maybe the capacity to handle that investigation within that time is not there. So that is the essence of risk control and management. Just also an example here. This is a case that this is a case picked from East Asia. I think might be probably Thailand, with regards to isolation management, isolation practices, patient isolation practices in an infectious disease unit. And the case in point here is the TB, the TB clinics, for example. So here, the team looked at how do we minimize the exposure to healthcare workforce and to patients in the event that a patient, for example, has been identified or is being suspected to have, let's say, a multi-resistant drug strain of the infection. So with this practice, a very simple engagement or practice that the team brought in place was just to have an IPC on call, an IPC lead on call that is available for the team within the setup, and also just to have just an availability of microbiology testing around the clock for the team that is providing the care. And you look at the approach that this team applied, you get the essence of the multidisciplinary nature of the persons or the workforce that is responding to the strategy, the single strategy of minimizing risks to patients and staff in the event that there is a patient who is suspected or thought to have a multi-resistant strain. So in terms of managing the system migration, from this practice, from this intervention, they realized that they were able to minimize overcrowding within the patient base, and also minimize the isolation room pressures or prolonged non-isolation of high-risk patients, which basically meant that most of their healthcare workers and patients were exposed to infection. So that is an element of risk control and risk mitigation. Yes, Stella, you can admit. Okay, thank you. The other strategy is monitoring adaptations and response. And here, looking at in monitoring, when you're implementing a patient safety strategy, we need to monitor its uptake, its implementation. For example, our focus here is to improve safety culture, and improving safety culture and intervention can be around patient and family engagement, whereby, for example, we're just trying to inculcate a culture of openness and error reporting and systems reporting. So here, you need to monitor how this intervention or strategy is being implemented. When you're looking at how the care teams responds to patient harm and adverse events whenever they are reported, that basically now looks into enabling the team to learn through their response mechanisms and also work through the system. Here, we'll be looking at how to develop your response team, whether it is just cross-checking the checklist, the surgical care checklist, or it's just cross-checking the hand wash stations or the hand washing practices, or it's just cross-checking on the patient identification practices, and also ensuring that through the system, you are also the capacity building this team to enable it be in a position to mitigate or respond to patient harms when they happen. The other focus area is ensuring that we improve the organizational management when harm occurs. For example, how do we develop, how do we predict times where we are going to have, let's say, staff shortages? And when we're having staff shortages or the unit is not at capacity to provide the care that it's supposed optimally, how do we now review or reorient the system with regards to, for example, risk controlling that at these particular hours, we cannot provide this care, but we'll be providing it this in a structured format, basically to manage the pressures that might come in. And also in terms for organizational focus and improvements, look at how to build the managerial capacity or the leadership capacity to deal with situations that come across the unit. And also with regulatory practices, negotiating time to move to new standards as we transit through the interventions or the standards of care, just trying to see how do we manage our times and how do we engage effectively. The last strategy, okay, this is also just an example here. And in terms of, this is an example from Uganda with view of improving IPC practices. And the intervention or the actions here, the team looked at how can they have a constant supply of, let's say, of sanitizer or hand washing commodities. And the action here, they looked at, they can produce this locally within their unit. They can have these dispensers, hand wash dispensers within the bedside or within the care delivery systems, and also have volunteer champions just to monitor the adaptation so that the usage of the engagements. So daily hurdles, basically the brief sessions that we have within the unit, just to check on this strategy or this intervention has been introduced, but how are we following through with it? The daily hurdles, this might be just 5 or 10-minute session, maybe at the beginning of the session or at the time that you are the care team is handing over to the previous sessions, similar to maternal safety bundles. In terms of the checklists and also the response time within the unit that is providing the care. And this one enables us to manage the latent contributors within the organization that point to, for example, resource gaps, and especially those ones that enable us to constantly shift drastically or drift progressively with the care or from the practice standard that is being set or is being established within the organization. Last of the strategies is the mitigation approach. So in mitigation here, we are basically looking at supporting patients whenever harm occurs and also supporting the healthcare staffs who are engaged or who are involved, and also supporting the organization with regards to now financial obligations, legal obligations, and also public and media response. So with regards to supporting the patients, when we are addressing a patient safety intervention or challenge, we need also to ask ourselves at the time that in the event that harm occurs, how do we support the patient to continue getting care? Or how is care handed over to the next care team? Or how is the patient kept in the know of the interventions that are going in to mitigate the harm? And with regards to the staff, how do we support the staff with regards to now also the issues that comes in around emotional strain and burnout, and also how to ensure that the staff involved in the incidents or in the patient harm challenge or incidents is able to stay in practice and also provide safer care for the next set of staff that are coming. With the organization now, we are looking at how do we support or how do we respond to the organization's core obligations with regards to legal protection for the organization, maybe there may be a claim that comes from the patient side, the family, and also with regards to building the capacity for proactive care. So this is also just an example in terms of safe surgery intervention. And these are examples, especially fairly within our setups. And so this the example here is a safe surgery intervention, and this was in Uganda. And the outcome we look at, for example, in terms of maternal
I think it's
sepsis
still
rates.
breaking.
Am I audible?
Hello, Oduor.
Yes.
Kindly check your internet. It's still breaking.
Or it's still breaking.
Oh,
Okay.
it's better now. Can
Am I
continue.
better? Okay. So this is an example from the Tanzanian healthcare environment. And through the intervention, they managed to basically reduce maternal death sepsis rates considerably. And also documentation through the documentation of safety, sepsis occurrences and initiatives. And with regards to this intervention, is my slide on, Stella?
Yes, strategy 5 mitigation.
Okay. So in strategy 5, it basically enables us to turn these incidents in patient safety incidents into improvement opportunities. So with that, these are just some of the key lessons from those implementations. So migration systems, safety migration is is a is a is a challenge that is there. It will always happen. It will always occur. So the intention here is that we deliberately step in to manage the migration so that we don't get into patient harm incidents. And in terms of how to apply these interventions or strategies, having the strategy is not enough. Ensuring that we adapt it to the local level so that teams are able to relate with them and apply them effortlessly. And the learning also that goes here is that these strategies should be applied in a blended format or in a blended fashion. You apply, you blend the low cost interventions and high structure combinations, whether it's just training or identifying a champion or just having a checklist, have a blend of the interventions or the strategies that we implement. And also implementation or success requires that we are able to follow through and sustain some of these. And the example that I picked here is the usage of national surgical and obstetric anesthesia practice safeties or plans within the countries. And most countries have these plans, some don't have these plans. And it also goes to the level of now the organization. You must have a framework that enables you to hold every strategy or every intervention in place. In terms of the tips, if you are looking at implementing some of these strategies, start with a situation analysis. Look at, for example, if a certain area of patient harm challenge, look at the past harm. Has this practice harmed a patient before? And would you want this area of practice to be reliable? Are we thinking of building reliability into the practice? Or how sensitive is this operation? Or how is the system prepared to absorb the shock or absorb the demand that might be coming in? Or how do we integrate these patient safety strategies into the learnings of the organizations? So that is the situation analysis that you'd start with, and ensure that whatever you do, you're trying to basically get a cultural fit, contextualize it to your organization. With this, you'll realize that out of the 5 strategies, some of them might be well applied within your organization, so you may have a lighter touch on them, and some may have a heavy touch on them. And the overall idea is to have a blend of these strategies in being implemented within the organization. And in terms of enablers, ensure that you are able to learn from the system itself and from the peers, from your peers who are implementing or handling the same kind of scenarios. And where possible, automation and digitalization now comes into practice. And an enabler, key enabler is the leadership commitment to implementing this strategy, and also with patient engagement or co-producing the safety that you'd want to build into the system with the families and those that provide that consume of the care. And tip also here is just consistently measure the implementation of these strategies and the uptake of them all. And in terms of timelines, do not look for a quick fix. Plan for the long term, 1 to 5 year programs as you blend these strategies through the system. So Stella, that would be all for that. And I just wanted to share with our participants with us. Let me see if I'm able to share the whiteboard. There is a whiteboard here. So I can pull this one down. If you allow me, I can pull that one down. And at that point, just a small engagement for us. So let me see if I can share it. Uh, I'm sharing something on the screen. Have you seen it? Are you able to see it, Stella?
Yes, it's visible, though it's tiny. You
It's
can
tiny.
increase the size of it here.
Is that better?
Yes, but now some of the writings are not visible. Some
Oh,
are missing from the other side.
where my cursor is?
We can see number 1 to 3
Yes. So
and the
let's start from
strategy.
number 1 to 3. So basically, this is
Okay.
just an invitation to us. So maybe within just from what we've highlighted and what we've spoken to, you can just tap on an area, for example, for best practice strategy or a checklist. Within the context of your organization, just an area that you are doing well, exactly as currently within that context for strategy 1, and an area that you see a challenge or a shortfall within your organization, and maybe one step action that you would be looking at. So this is just a session. Maybe we can have an interaction maybe in the next 10 minutes just to see where we are and what we pick out of the interventions and the strategies. So it's free to edit. Anyone, you can just type and so if you are having a challenge, probably you can just type in the checkbox and we'll respond, or you can raise it up. Stella, from your
Yes.
end, are you able to type?
Yes, I'm able to
Yes.
type.
Okay, so yes, I've seen Miriam, I've seen Beth, Bisheha.
Meanwhile, I don't know if Grace managed to join. Grace, are you with us? Okay, looks like Grace didn't manage. So as we do the exercise, also feel free to drop any questions in the chat. I see someone.
Hi, Stella.
Hi, Grace.
Yeah, I'm saying a very good presentation there from on war, very insightful, and yeah, I think it's really quite timely at such a time like this. You can just continue. Yeah, thank you.
Thank you so much.
Yeah, so colleagues, just look at the strategies, just if it is a strategy one, best practice, something within your context that you will pick as a strength from your organization where you practice, something you'd pick as a weakness or a key gap or a shortfall from your end. And then we just we review in the next 10 minutes to see what we have.
Probably we could try and just hurry up because of time. We need to really be winding up. Thank you.
So for example, in terms of process improvement or patient handovers in your organization, what strength do you have around that? Or what weakness do you pick around that? So in terms of, for example, now as risk control strategies, in terms of triaging, what strength do you have around that? What do you see around that? Yes, I've seen one strength. We use surgical checklist at duty RH. Thank you. Yes. So monitoring, I've seen a dashboard filling gaps. Okay, thank you. Team handovers, okay. So for the surgical checklist at, for example, at GTRH, anything that you'd pick as a gap on it? Team handover at shifts. Okay, great. That's a strength within that organization. I think, let's see. Okay. Yusra Awad, I've seen you, Doc. Seen you typing something. Miriam Githuka. Okay, Elizabeth, thank you. Baristas Chebi, thank you. Okay, there's a gap here, gaps in filling the checklist, the WHO checklist. That's a gap. Okay, thank you. Team handover during shifts. Okay, process improvement. Yet to see anyone who's typed any practice they have around mitigating, responding to patient harm when a patient is harmed, a strength they have or a gap, something around there. For example, when a patient is harmed. Yet to see something typed there. Risk control strategy. Okay. Yes, Dr. Kiri there. Okay. Grace, how long are you giving us? How many more minutes?
Can you hear me?
Yes, I can hear you.
Yeah, I'm saying you can have, now it's 2 minutes, so we finish at, winding up, we finish at 10 past 4.
Okay, we finish at 10 past 4. At 10 past 4, we'll finish.
Yeah.
Okay. Okay. So colleagues, the essence here is that, for example, when you're using the surgical safety checklist, the patient safety challenge that the surgical safety checklist is supposed to address should be accompanied with other strategies or other interventions. For example, around process improvement. If you pick about team handover at shifts, let's pick now team handover of the surgical case from the theater from the ward to the operating room, back to the operating room, back to the ward. So those handover in terms of systems managed. So that is the essence of it. Looking at now systems risk control in the event that there is how do we manage, how do we triage, for example, the surgical patients, whether it is emergencies or the electives, and how do we monitor the uptakes of this checklist, and how do we step in to mitigate patient harm incidents when they occur around that intervention that the surgical safety checklist is supposed to address. Okay, there's use of surgical safety checklist I think this should be cost general teaching and referral hospital. Thank you, Yusra. So that is the essence of the interventions being implemented in a bundle, so that the interventions are not implemented in isolation, whereby we may not realize the full breadth or the full outcome of the interventions that are being implemented. So I believe from this brief, you have an idea of whichever patient safety strategy or all interventions you've been implementing. You can go back and rework them and look them through the entire bundle of strategies. So I think that should be enough practice for us with the whiteboard. I would stop. I would close it. I'm closing it now. So colleagues, thank you for sharing. Thank you for sharing your practices and insights. So this is where we are. That is what this session was meant to help us achieve. And so in summary, this is just a summary of what we have. There is no one-size-fits-all strategy. We have to apply a blend of them based with the fact that all our clinical environments are diverse, and they have their own different kind of challenges. But within the bundle, we look at 2 care optimization strategies, that is the first and the second, and then 3 risk management strategies across the essential pathway. and ensure that with each and every patient safety challenge, you will implement a portfolio of these strategies with the family of interventions that you may be looking toward. And as advised earlier, just ensure that you contextualize this to your own organization with a view of building reliability within your systems and also managing the dynamic settings that we have within each and every organizations, and then providing a procedural underpinning for all the patient strategies across the organization, across the system, within the whole interventions. So as always, this is basically our moment with an elder. Most of the work that we referenced previously in the last session and this session is work done by Professor Charles Vincent, and he basically reminds us that understanding how to make care safe is hard, and actually making it care safer is harder still, simply because the healthcare environment is very diverse, it's very complex, it's always having emergent issues. And we've seen the workforce challenges, we've seen the issues around resource constraints, we've seen issues around poor data management and stuff like that. So that is why the healthcare making care safer is fairly harder, simply because the environments are not the same and it's always shifting and moving. And systems migration for safety will always be with us. So I think that is from that. And that is just a snapshot of the references, some of the references that were provided that we've used for the session. So thank you, thank you, Grace and Stella and colleagues. So I'll end the session there, waiting for maybe any questions that might have come. Thank you so much. Grace, back to you. Hello, Stella. Grace.
Hello,
Is not
looks like
okay.
Grace.
Okay.
Yes, my name is Nuruddin. I wanted to say thank you, Dr. and your team. Thank you, the good presentation. Just I need to appreciate your great work you did. Thank you.
Thank you, Norodin. Thank you for finding time and joining us.
Hello, can you hear me? And Radin, thank you so much. Can you hear me?
Yes, I can hear you, Grace. Go on.
Oh, I think my net probably has been shaking, but I just wanted to say thank you, and thank you everyone for really joining us for this session. Remember, we are following up from the first session that we had on system migration framework. And now we are looking at how patient safety strategies can be utilized in resource limited settings. And I think this is really relevant to all of us. So just a reminder, my name is Grace Achieng. I'm an associate with Systems Evaluations Limited. Just reminders of the services that we have. So our services, we are basically measuring in safety and quality governance, revenue cycle management, and also research and learning. Our service intentions on building sustainable programs, building learning solutions, and building better health systems. That is our passion. So we want to also request, if you can, please share these links as you see them with as many as possible. And we are also privileged to give us the latest and what is really relevant for us. Udur puts in really so much in this. So thank you so much also, Udur, for the presentation, and we look forward to really getting more time and learning more. Feel free also to give us feedback on the chat, and even if not today, you can still follow up through email, and we'll still be able to get back to you. So thank you so much, and God bless you. Over to you, Stella, to just close for us. Bye, everyone.
Thank you so much for our participants and to Adwar for presenting passionately, and also for Grace for moderating this session. I've dropped a link in the chat for the exit survey. Feel free, it helps us improve, know what you need most, and where we can improve the sessions. And also follow us on social media. We are on Facebook, we are on Twitter, we are on LinkedIn. Can also send us emails, also interact with us on our website, and learn more about the services that we offer. Otherwise, I was your host, Stella Oiro, and I really appreciate. Until next time, thank you.
Thank you so much. Yes, I've seen colleagues requesting the slides. The slides will be available in the coming week on the emails that were used for registration. I think, yes, so the slides and the materials and the recording will be available. Thank you so much, Stella. Thank you, everyone. Thank you, colleagues, for finding time to join.